National Advocacy Forum. As you all know, we're having the webinar series on advocacy, and today with us we have Dr. Ndidiamaka Amutah-Onukagha, who is a phenomenal researcher and public health advocate with us. So just a little bit of like background on Dr. Amutah-Onukagha, which is funny, who is funny called Dr. Ao, for those of you who don't know how to pronounce the name. Dr. Ao is the inaugural Julia A. Okoro Professor of Black Maternal Health at Tufts University School of Medicine, and she is the founder as well as like the director of the Maternal Outcomes for Translational Health Equity Research Lab, which hosts 33 future clinicians and public health professionals. The Mother Lab basically has like a focus on addressing and eliminating maternal health disparities. Dr. Ao received her PhD in public health with a focus on maternal and child health at the University of Maryland College Park School of Public Health. She has a long-standing commitment to public health that spans over 15 years of experience. Her current research interests include maternal mortality and morbidity, health disparities, reproductive health, infant mortality, and HIV and AIDS in women of color. She's a co-chair of the American Public Health Association Perinatal and Women's Health Committee. She's also the director of the Tufts University School of Medicine Black Maternal Health Center, or rather the Center for Black Maternal Health, where she strives to protect the Black birthing experience by advocating for quality, equitable, and respectful care in childbirth. This is just like a short list of Dr. Ao's like numerous accomplishments. And with that said, I would have her take the floor.
Great. Thank you, Blessing. Good evening, everyone. I'm happy to be here with you all and have this conversation. I look forward to us having a robust conversation in the Q&A period tonight. So my talk with you over the next 30, 40 minutes or so is really thinking about strategies we can use to improve Black maternal health outcomes, and then focusing on things that you all as future clinicians can look at. So starting off the talk, thinking about what exactly is public health advocacy, right? How do we work with advocacy groups? How do we create opportunities for engaging in a social justice response to addressing a maternal health crisis? We know that raising awareness regarding public health risks and concerns, while also focusing on collaborating with key decision makers, community members, and practice leaders, are really some of the best ways to go about improving maternal and child health while building community and bringing together a collective power that calls for action. When you're thinking about maternal and child health and what the impact of maternal health inequities is on the birthing experience, we really know that anyone can advocate for maternal health, right? And so thinking about these three buckets, focusing on human rights, looking at the government and the way that they are ensuring that everyone has access to respectful maternity care, focusing on equity, which is the allocation equally of resources while removing systemic barriers and systems, really focusing on supporting marginalized communities, and birthing justice, which is looking at how do we empower and support birthing people to make informed, independent decisions about their reproductive future, reproductive autonomy, while considering the determinants that impact those things. So the IOM, the Institute of Medicine, defines health equity as healthcare that does not vary. So there's no change or variability in the quality because of personal characteristics such as gender, ethnicity, race, geographic location, socioeconomics, etc. So you're looking at the equitable distribution, the equitable provision of healthcare with no reduction in quality, no reduction or no difference in change because of these determining characteristics. Interestingly enough, the Robert Wood Johnson Foundation says that 30% of people's health is impacted by their personal behavior. So what people do on a daily basis and how that plays out into their outcomes. The other 70% really stems from social and economic factors, physical environment, clinical care structures, and access to care. So what are we here to discuss tonight? How do we address the problem in thinking about maternal and perinatal health outcomes? So looking at the data, we know that the rates are getting worse. This is the latest data we have publicly available. It's from 2021. It was released in February of this year. And when you look at the maternal mortality rates, which is the death of a maternal or birthing person per 100,000 live births, we know that the rate for non-Hispanic Black women is significantly increasing. It was 60, I remember giving this talk and it was 55.3, and now the latest data we have is 69.9. It's also increasing in all other groups as well, right? It's not just Black women, but we see that there's an increase in the overall maternal mortality rate. And when you look at it from 2018, which is 17.4 deaths, to 2022, which is 32.9, we know that represents a significant increase over that really short time frame. When you look at it by age, it's even more stark. The rates of maternal mortality and severe maternal morbidity, which are illness, increase dramatically with age. We know that the rate is 20.4 deaths per 100,000 live births under the age of 25, but that increases exponentially for deaths to women 40 and over. And the rate for women 40 and over is actually almost 7 times higher than the rate for women under age 25. And this is important because as we think about messaging, we think about our patient population, we think about the ways that we want to interact with people who are taking advantage or really benefiting from the healthcare system or engaging with the healthcare system. We want to focus on how do we prioritize care, how do we meet people where they are, and how do we stratify or are more intentional about the care we deliver, particularly to our birthing people 40 and over. Thinking about Black maternal mortality, as I mentioned, the rates for non-Hispanic Black women are almost 3 times higher than the rates for white women. And even the rates for white women are increasing, but we know that this is a really big problem. It creates an opportunity for disparities to persist. It creates an opportunity for inequities to really thrive when you look at the overall maternal mortality rate by race. So most states, 36 states, and other territories have what we call MMRCs, which are Maternal Mortality Review Committees. Now, these review committees are tasked with a really sobering job. They meet and they look at cases of maternal death. So they review the person's family history, they review what happened, did the person die on the day of delivery, did the person die up to 365 days after delivering. They look at all these pregnancy-related deaths and they come up with assertions or recommendations for things that can be improved or changed. Now, we know that the pregnancy-related death rate is highest, and for this particular graphic at 62.8 for 100,000 live births for a non-Hispanic Native, Hawaiian, or other Pacific Islander, followed by non-Hispanic Black, and also non-Hispanic American Indian. So these are the 3 groups that we really should be prioritizing where we see the bulk from these 36 states. So it's not every state, it's not every territory, but the majority of states do collect this data and do have these recommendations on a regular basis. What they also found in their work from 2017 to 2019, so this is not captured data from the pandemic up until now, so it's a little bit earlier. But what they found, and the numbers may have shifted slightly, but not much, is that 22% of pregnancy-related deaths occurred during the pregnancy, from 0 to 9 months, right, up to 40 weeks or so. And then 25 or a quarter of the deaths occurred on the day of delivery or within 7 days after. So we know that that immediate postpartum window is a window of critical importance, and it's a window of opportunity and engaging and re-engaging patients with the healthcare system, particularly patients that we know are high risk based on the data that I showed you earlier. We're looking at Black birthing people ages 40 and over, but 53% of the deaths actually occurred from 7 days to 1 year postpartum, right? And so we know that the postpartum period, or as we like to call it, the 4th trimester, is a critical window of intervention and provides an opportunity for the engaging of care and, frankly, the reentry of care for people that need it the most. The biggest, most stark finding that this MMRC found is that 80% of pregnancy-related deaths in the United States are preventable. So that's pretty jarring, right? Because you have 10 birthing people, you line them up, that means 8 of the 10 of them that died were completely preventable. So why are we saying this, and what does this mean for the work that we're doing? What does this mean for you all as future clinicians? Some of you who will go on to obstetrics and gynecology, some of you who will go on to be MFM, some of you who will go on to be family practitioners, some of you that will go on to do all of these other areas that interact with birthing people across the continuum. What does this mean? Well, one thing that we have to look forward to is the work that was done in the space of infant mortality. So some recent work by my colleague Rachel Hardiman and her team looked at cultural congruence of providers and patients. And in the case of infants, they found that when the infant and the caregiver were of the same racial and ethnic background, the rates of infant mortality actually dropped significantly. Now, we know that the issue of infant mortality is not a new problem. Infant mortality is defined as the death of an infant between 0 and 365 days of life or up to 1 year. And the infant mortality rate is a significant indicator of the quality and the health of a nation and how it treats its most vulnerable populations. I wrote my dissertation on infant mortality almost 15 years ago. We have not really moved the needle on what this looks like. And we know that the cumulative infant mortality rate is 5.42 births per 1,000 live births, right? So rates of 7 or more, so you can look at this here, the darker shaded gradient really shows where we have the most burden of infant mortality and frankly, where we have the most opportunity. And so we know that the majority of those are located in the southern states, but 12 states had infant mortality rates that were lower than the national rate, while 16 had rates that were significantly higher. So this is another place that we need to move the needle. If we're not taking the absolute best care that we can of our birthing people and of our infants, then we're really missing the mark in two very important populations to be able to center their care and to keep them alive. So how do we think about disparities in maternal care? Well, as I mentioned, these MMRCs have their findings, and here are the things that they have highlighted as the main reasons for these disparate outcomes, right? Access to care. How far do you have to travel to get healthcare? What is the quality of that care? How does that differ by geographic location, right? What is the prevalence or the current existence of chronic diseases? Are we seeing a population that is more likely to have gestational diabetes, gestational hypertension? These things we know exacerbate adverse maternal health outcomes. What is the quality of clinical support? Are they able to get the wraparound services? Are people able to have access to a doula, a midwife? Are they able to have access to a maternal fetal medicine doctor, an OBGYN? And then the impact of structural racism, right? And so this came up as one of the main findings in their work. And the interesting thing about structural racism is that it's not one or two bad actors. Structural racism is actually a system, right? Where public policies, institutional practices, cultural representations work together to reinforce, exacerbate, and really highlight racial inequities. It's not one or two bad actors, it's the cumulative impact on a system. Now, we know that this is not new, right? Structural racism has been around for a long time. It's absolutely embedded into the history of medicine. And throughout US history, women of color have suffered many reproductive injustices. We're thinking about the work that happened in the 1960s with Fannie Lou Hamer and the Mississippi appendectomy, which was a term that she coined to think about how Black women were getting the forced sterilization that occurred, and particularly in the Deep South, and thinking about what does that mean for the unconsented, unsterilized treatment that Black women were receiving. We also know the work of J. Marion Sims and thinking about his tactics. Up until recently, he was considered the father of modern gynecology. People really thought that his techniques and his surgical prowess were really something to be impressed by. But when you dig, and you don't have to dig that far, you realize that he perfected his techniques on the bodies of Black enslaved women, right? And so you're thinking about how does the field of obstetrics and gynecology, how did he learn how to do these things? How did he learn how to have, to remove, to repair fistula or to utilize a speculum, all these things that were really perfected on the bodies of Black enslaved women. There are three in particular that we know of: Betsy, Lucy, and Anarcha. And these women ultimately sacrificed their bodies without their consent for the history of medical knowledge, of the history of medical advancement, right? And so this person, who up until recently people thought was really amazing, was actually not that great. I'll talk a little bit more about him in the next slide. But when you're thinking about the impact of racism in maternal health, right, we know that upwards of 60,000 women are affected by severe maternal morbidity. So this is not maternal mortality, which is the death. This is severe illness. So think, someone having to be readmitted for complications, think of maternal hemorrhage, etc. And we know that these near misses are really important because Black women have a 70% increased risk for severe maternal morbidity, but are also twice as likely to experience it, right? This is particularly cumbersome because, that Black women in particular sit at the intersection of race and gender. And so this intersectionality that is part of the lived experience of Black women in this country is affected by tremendous chronic stress. So you're thinking about the reproductive physiologic impact of cumulative chronic stress. You're thinking allostatic load. You're thinking higher blood pressure. You're thinking the shorter telomeres. Black women's reproductive physical health is 5 to 7 years older than their white counterparts, which is why for Black women 40 and over, it's particularly problematic when you're thinking about pregnancy and childbirth. And these are the things that are really exacerbated by racism. So as I was mentioning about J. Mariam Sims, up until recently, his work was considered amazing. And the work that he did was quite problematic. He would operate sometimes upwards of 20 times on a single patient. And then once he perfected his technique, he went on to really do this surgery in Europe, where he was able to offer anesthesia and sedation to white women who would benefit from these newfound techniques that he had. Here are the pictures of 3 of the women. This is like an artist rendering. We know that there were many more. There were up to 12 women that lived in a makeshift hospital shelter behind his house. He built it in Alabama between roughly 1844, 1849. But this exploitation really led to the foundational advances in obstetrics and gynecology, and the techniques are still being utilized very heavily today. So speaking of today, we know that there are a lot of many modern day challenges in the field of obstetrics and gynecology in the healthcare delivery system as a whole. Racism and equity are embedded and they show up in the delivery of healthcare. We know that hospitals and clinics that were designated for underserved communities continue to experience significant financial constraints, often end up being under-resourced and improperly staffed. There's a systematic segregation and discrimination that occurs. And this continues to happen either based on insurance status, which disproportionately impacts Black and Brown populations. It can also happen from language, from immigration status. But these inequities are major contributors to racial and ethnic health disparities, and they exist despite the birther's level of education and socioeconomic status. So this chart that we're looking at, this graphic here, that really focuses on the factors of systems that influence maternal and perinatal outcomes, are really focused on 4 kind of buckets, if you will. So this is what we consider to be the social determinants of health that impact someone's perinatal outcomes. We're looking at the policies, the financing, what is the culture of health systems and how do they prioritize patients of color? What are their thoughts and what systems do they have in place to really make sure that patients of color and all birthing people are able to get the care that they need? What is the impact? How does institutional racism play out? So is it where they say, oh, this is how we treat everyone the same. This is what we've always done. This is the system. We can't change things, right? What is the impact? How is institutional racism embedded into delivery of that care? What are the community and care provider factors, right? What is the personal biases that providers come into the room with, right? What are the competing demands on people's times, and how are they able to make sure that their patients are getting what they need? What about internalized and interpersonal racism? How does that play out? What is the skill base of the providers that are dealing with these different populations, right? And in thinking about the birthing people themselves and their family and the lens that they come to the clinical encounters with, right? Where do they sit in internalized racism? How do they see themselves in the healthcare system? What's the culture and communication preferences? Do we need a translator, right? Social resources. Do they have to take 3 buses to get here? What is their current health status? What is their work and living conditions, economically and otherwise, right? And so thinking about the systems, the societal factors, also at the individual and family levels, these are the things that kind of interact to most times negatively impact maternal and perinatal outcomes. So in my TED Talk that I did in February 2022, I talk about the impact of racism and discrimination on adverse maternal health outcomes. And I talk about really how provider racial bias results in poor health outcomes and can really be a negative influencer of diagnosis and treatment, pain management, what are the relationships, the opportunities for developing a clear and mutually beneficial, culturally humble patient provider interaction. How do we create spaces of patient centeredness, patient autonomy? What does this look like in labor and delivery? How are patients able to create the birthing experiences that they want and to be able to labor with joy in the way that they want to bring life into the world? What are some poor experiences with hospital staff, and what does that mean for patients' dissatisfaction? How do people ultimately end up avoiding the very healthcare system that was designed or should be designed to protect them and to center their needs, but because of this dissatisfaction, because of the history around mistrust and distrust, we talk about the case of J. Mary Sims, these interactions with healthcare professions stem from stereotype threat, right? There's a fear, there's a pronounced fear of prejudice and racial discrimination that plays out in provider implicit biases that ultimately has a direct correlation to maternal health outcomes, particularly for Black and Brown birthing people. So if you want to watch the TED Talk, it's on YouTube. Just put my last name, Amutah or Amutah-Onukagha, in YouTube TED Talk. It'll come right up. It's about 13, 14 minutes. But I talk a lot about what the impact of racism in the healthcare system looks like. Oftentimes people want to see the data when it comes to a topic like this, like how have we quantified, the experience of Black and Brown birthing people, and do we know that people are actually getting mistreated? I get this question often, and so this study is a little bit old now, but ultimately they reported that some women, this is probably underreporting, reported experiencing one or more types of mistreatment, patient mistreatment, such as loss of autonomy, being shouted at, being scolded, reprimanded, being ignored, being refused requests for help. Almost 30% of women of color with low socioeconomic status reported any mistreatment versus almost 20% of white women with low socioeconomic status. So again, income, right, and thinking about all these other determinants, both of these groups are low income women, but we see a more pronounced reporting of mistreatment in low income women of color. All women who identified as Black, Indigenous, Hispanic, or Asian reported higher than average experiences of mistreatment. Regardless of maternal race, though, having a partner who was Black also increased this reported mistreatment. And so it's not just the birthing person, it's having a partner that happens to be Black that increases someone's likelihood of being mistreated by healthcare providers. So, what is the goal? The goal, obviously, is to create spaces of collective vision while maintaining respectful maternity care, right? We know that reproductive justice sits at the intersection of reproductive rights, human rights, social, political, and economic inequalities that impact a birthing parent's ability to access quality reproductive health services, but also thinking about some of the ways that these kind of play out across the delivery of care, right? So, birth equity is a space that assures quality conditions of optimal births and well being for all birthing people with a willingness to address racial and social inequities in the healthcare delivery system. Understanding how intersectional identities of birthing patients, parents, including race, gender, sexuality, socioeconomic status, play a role in reproductive justice, thinking about culturally competent care and holistic maternity care, right? Reinforce professionals' commitment to inclusive and equitable care and bridging these care gaps while ensuring confidentiality, respect, cultural sensitivity are upheld, and these practices are done through culturally competent providers, right? And so these are spaces where we can really create the type of birthing experience that we would want to go through ourselves, that we would want our family members to go through, in a space that is respectful and that centers the birthing person's rights and autonomy. We also want to make sure that we're being intentional about advancing maternal care with a racial equity lens, right? We acknowledge the complexity of sexuality and reproductive decisions while promoting reproductive autonomy, health, and well being. Also ensuring culturally responsive reproductive health information is available. Are we delivering culturally competent care? Are we providing information in people's languages that they can understand and prioritize as they make healthcare delivery decisions, while applying an intersectional and social determinants of health approach to these reproductive choices, to these issues, right? Really acknowledging the role of racism and healthcare disparities. But most importantly, we value the voices and lived experiences of the people whom we aim to serve. That's really how you advance maternal care with a racial equity lens. So, how do we create spaces where we are able to demand change while advancing maternal health care, right? I think this is one of the spaces that really provide an opportunity for us to do work in the advocacy space. We know that culturally competent care is crucial. It's critical for promoting equitable and effective maternal health care and protecting the birthing experience, right? While making sure that we're able to improve maternal health care delivery, but also really thinking about what does this mean from pregnancy, childbirth, and the postpartum period through training, through education, community engagement, and training, education, communication, and community engagement. These are the pockets that we're thinking about, and many others, frankly, for the ability to provide this crucial window of opportunity in a birthing person's life and in their birthing trajectory. So here are some places where we can really advocate for policies, and I would encourage you all to see what's happening there in your local area and support elected officials, state level, federal level, who are focusing on these. We do a lot of this advocacy and policy work here in Massachusetts through my Center for Black Maternal Health and Reproductive Justice. But thinking about the Black Maternal Health Omnibus, which is 13 individual bills that seek to address the underlying drivers of maternal morbidity and mortality, right? Well, thinking about how do we improve the equitable process of data collection? How do we make sure that we're collecting data in a way that centers the Black and Brown birthing experience, implementing community-based and focused maternal health policies, addressing social determinants of health? And then we have the Mommies Act, which is maximizing outcomes for moms through Medicaid improvement and enhancement of services. So how do we make sure that we're increasing the coverage for pregnant people while providing comprehensive, affordable maternal health care services and expanding Medicaid to cover postpartum and doula services? Here in Massachusetts, we just got a grant to think about the ways that we can partner with doulas to make sure that the care that they're able to deliver, and we know the doulas are an amazing resource. They're trained healthcare professionals that support the birthing person in birth, postpartum, and in the prenatal period as well. How do we make sure that they're reimbursed equitably while allowing them to improve their access and create opportunities to culturally appropriate maternal care services? So when we think about engaging partners, every time I give this talk, it's people always ask, what can I do? What's a role for me? Well, obviously the goal is to make sure that communities are better off than when we started research, better off than before we started the research project, right? You want to be able to engage communities, you want to engage patients, you want to engage stakeholders. They are partners in the research process. Any project that I do, any research study that I do, I'm happy to chat more about this in a Q&A coming up, but the engagement of communities, patients, and stakeholders is part and parcel of community engaged research, particularly in the space of maternal health, right? And thinking about how you frame research questions, thinking about reproductive justice and what that looks like at the community context, and you're asking yourself as a researcher, as a clinician, as a provider, how, when we're designing, we're conducting, we're communicating health research, do we promote justice for communities? These are especially important when considering that some communities may be considered vulnerable in the research process and potentially have the most to gain from advances in research for social, economic, or historical reasons. And so we really want to be intentional about this partnership. We can also, once the data has been collected, once we're in a space of actually promoting the findings, utilizing culturally responsive, community-driven, anti-racist approaches and tools to address racial disparities, prioritizing preventing chronic disease in the first place, shifting our focus away from specialty care to primary care, right? This preventative thought, ensuring equitable access to high quality care, addressing patients' social risk factors, fostering and creating diversity within the healthcare workforce, just like all of you here tonight in SNMA, improving maternal morbidity and mortality data collection at the national, local, and state level to overcome some of these challenges and really create opportunities for accurate reporting of data. So I'm happy to chat a little bit about the work we're doing here at my research center. Center is about 1.5 years old, and we're focused on addressing this problem, right? Where we're thinking about how we can prioritize the Black birthing experience by advocating for quality, equitable, and respectful care in childbirth. We know that Black women are 3 times more likely to die for pregnancy-related complications than white mothers. We know that Black mothers experience higher rates of hypertensive disorders, such as preeclampsia and eclampsia, as well as higher rates of hemorrhage and cardiomyopathy. And we know that the infant mortality rate is staggeringly more high in Black infants than in other infants. So how do we create opportunities for addressing these, for calling out racism in the healthcare system? Our blueprint is really to combat Black maternal mortality, right? The mission of the center is to foster academic and community-engaged research in support of our center's goals, which are really around conducting maternal health research with the focus on Black maternal health and the elimination of inequities. And so to do that, we have 6 units here at the center. Mother Lab, which is my student group of student advocates from undergrad, master's, post-bac, MDs, PhDs, residents who are focused on addressing maternal health inequities. Mother Lab stands for Maternal Outcomes for Translational Health Equity Research, and so the website is motherlab.org. But Mother Lab is student-led, student-driven, with the focus on maternal health. I also have a research development, a philanthropy and grants unit, a health epidemiology and data synthesis unit, a focus on policy. We talked a little bit about that earlier with the Momnibus and the work they were supporting here at the state level in Massachusetts. Education and training. Here's where we're going to be rolling out some training and curricula for doulas and midwives and focusing on community engagement. How do we really create and sustain partnerships with community-based organizations who are doing incredible work in this space? So to accomplish our goals, we really are thinking about it from 3 kind of bullets, right? Collective action. How do we address the disparities that are central to the mission of the center through the ability to shape and support federal, state, and local legislation that impacts policy? How do we create and sustain ourselves as a hub of maternal health research through this fostering of data with a particular focus on Black birthing persons and their babies, thinking about the resources and the expertise that we have in-house? How do we create equitable access to the delivery of healthcare, the provision of healthcare services, the diversity of the workforce, right? Where we're able to create a world where Black women can safely, efficiently, and comfortably receive equitable access to healthcare services without having to navigate through racism and or discrimination in medical settings. So these are kind of our 3 marching orders, if you will. Here's the amazing team that helps me get it all done. I'm the founder director. I also sit over our research and development grants. Candace is my unit lead for our Mother Lab. Dr. Shrestha is my epidemiologist. Dr. Ashford is my policy director. Dr. Hudson is my director of community engagement. Sunday is my center manager and also manages the education and training unit. And then my amazing administrative team is my senior administrative coordinator, Alicia, my communications director, Jennifer, my events coordinator, Judith, and my program administrator, Subetcha. So here's my amazing team that really focuses at the heart of this intersectional, multidisciplinary group of professionals dedicated to advancing and advocating for quality, equitable, and respectful care in childbirth. So I'm happy to chat further. Just a little bit about the Mother Lab. We really are about almost 3 years old, and as I mentioned, there's 35 students who are focused on 3 main committees around research and grants, marketing, communications, and events, and then community engagement, advocacy, and policy with the lens of writing scholarship, contributing to the scientific literature, and also focusing on mentorship. So here's some of my amazing staff and my Mother Lab students. I'm very proud of them. And here's our contact information, my email, my personal Twitter, and then the Center for Black Maternal Health Reproductive Justice, our Instagram, Facebook, and Twitter, Mother Lab's Instagram, Facebook, and Twitter, and then our Black Maternal Health Conference we do every year during Black Maternal Health Week. So the next one is Friday, April 5th, 2024. It's going to focus on the role of technology in addressing maternal health disparities. So think AI, think digital health, think wearable devices. And so please follow us on our social media at BMM Tufts for updates and registration. We just finalized our speaker lineup today. So we're going to be opening registration later in the fall or at the top of spring. But please hold the date, Friday, April 5th. All right. Happy to answer any questions. Thank you all so much.
Amazing. Thank you so much, Dr. Ayo. That was really great. Every time I listen to you give a talk, it's like I feel energized.
Yes, that's the goal.
So for those like who are on Facebook and YouTube, please feel free to drop comments in the chat, and we can read those out for Dr. Ayo to answer. But in the meantime, we do have some prepared questions for you. One of those, as you talked about, like how Black women nationwide are 3 to 4 times more likely to die from pregnancy compared to white women. Can you just give like a little bit more context on what you think is going on in the hospitals or clinics that's driving this disparity that we're seeing?
Yeah, and that's a great question given this very clinical audience. For me, I think it's the insidious nature of racism. Racism is very dangerous because it comes in and it seeps its way into the healthcare system, and it's so insidious. It's everywhere. It's in the way that people are treated. It's in how long a provider stays in a room. It's do they even sit down? Do they make eye contact? Do they introduce themselves? Do they shake the patient's hand? Like all these small little microaggressions really translate to a delay in care, a delay in prioritization of this particular patient. Oh, that patient in room 114, they're considered non-compliant because they may have come late to a visit, or they may have brought their kids because they don't have childcare, or they may not have, filled out their paperwork on time. All these biases play into all these deliveries. So that's how racism is so dangerous, because those small missteps, those small delays in care, cumulatively, they place the person at increased risk of something bad happening. So, yeah.
Thank you.
Mm-hmm.
Okay. So the other question that we have here is, so just considering like what's going on in the hospitals and the things that you just cited, what would you say to like encourage women people who are giving birth to look for when choosing like a provider? What questions should they ask to ensure that they're getting the best care?
That's great. Well, I know when I was thinking about when we moved to Boston and we knew we wanted to have children, I started doing my research on providers. So I'm like, okay, where can I get a team that's mostly Black and brown, if not all Black and brown, in a majority white space like Boston? And so that's how I made my decision. I also looked at C-section rates of the hospitals. I looked at the reviews online. Luckily, we have, and my center is about to start a formal partnership, but I don't know if anybody here has heard of the IRTH app, IRTH app, but it's like a Yelp for birthing people, for doulas to give feedback on providers and their clinical experiences and what happened in that delivery of care. It's amazing. And it's not in every state, but it's in some major markets. We're actually about to start doing the analysis of the data and really trying to make heads or tails of what they've collected so far to see how we can provide recommendations. So that's what I would say, is to like look at existing data online, look at the C-section rates, look at the leapfrog, which is a ranking of hospitals and their quality. Talk to other birthing people, what their experience was like. I think word of mouth is very important. And then also trust your gut, right? Thinking about the relationship. I remember when I first moved to Boston, when I'd gone for my annual primary care visit, and I told the woman that I wanted to have a baby, and she was just like, did some very basic lab work and was like, all right, see you next year. I was like, can we check my blood pressure? Can we talk, like, you know what I mean? Like, let's have the conversation where the person feels like they're engaging in healthcare delivery. So I never went back to that provider. And, when I have my annual exams, I'm in there for an hour and a half, right? Like, I want to get every question answered. I want to make sure that I feel very, very supported and prioritized. And recently I was getting results of a mammogram, and the provider came in, she didn't sit down, she didn't introduce herself. And I said, well, I need you to go back out and come back in as if, there's some respect. And so she was all like flustered, right? Because who knows how many patients she had that day, and she's running to give results. First of all, thank God the results were fine, but even if they weren't, this is not how you want to set up the relationship, right? And so just thinking about ways that providers can be held more accountable. So I asked her to leave my room, and she came back and she knocked on her door and she introduced herself, and I introduced myself. And then we had a lovely conversation and it was all good. But no. So, but again, I also recognize the privilege and the agency I have in this space because I do this work, et cetera, et cetera. And so I don't mind pushing a little bit more. I do want to put like that little asterisk out there and say that many birthing people do not feel that sense of agency and that sense of privilege to be able to push back on providers, because providers are seen as being the experts in the room. So these are some things that I tell people that, providers work for you, right? If you're not delivering at that hospital, if you're not getting care there, then that's less money that they can reimburse. That impacts their bottom line. So you want to be in a space of power and shared decision making with your clinical team.
Great, thank you so much. We have a question here in the chat from A. Simpson that says, how are the maternal mortality rates, the maternal morbidity and mortality rates, how do they compare between the public versus private sector? I guess giving birth in public versus private hospital, are there any differences in like the rates?
Mm-hmm. They're both bad. They're both bad. I've looked at claims data from private insurers. The majority of births in this country are to women on Medicaid, birthing people on Medicaid, which is public insurance. They're both bad. I was really pleasantly, not pleasantly, but unpleasantly surprised when I looked at private claims data to be like, your rates are not that much better. So private is a little bit better than public, but there's really no difference. It's just, again, how racism shows up in the healthcare delivery, but there's really not a huge difference, unfortunately, in outcomes by insurance status.
Okay. The other question from Brianna says, would you happen to know of organizations in the Washington, D.C. area that are doing work similar to what you're doing with Mother Lab?
Well, first of all, Mother Lab is virtual. You can do this work anywhere. So if you're interested, you should send an email. But second of all, in the DC area, I would probably, funny enough, one of my Mother Lab students works there. Mama Toto Village, which is a birthing center in DC. They're doing amazing birth equity work, reproductive health work. I don't know of an academic-based research center. Like, we still sit at a school of medicine. I'm still a professor in a school of medicine, so I don't know any other schools in that area that have that configuration, frankly. But in DC, I would look at Mama Toto Village. In Baltimore, like if you're looking up that way, I would look at the work. University of Maryland School of Medicine in Baltimore County just started doing some work in the maternal health equity space. So that might be another place, but I'm not thinking of like something like my Center for Black Maternal Health or something like Mother Lab that exists in that area.
And then a question from Princess says, can you speak a little bit about how fathers or like the parents supporting system or the present supporting system can help advocate for the birthing person?
Sure. I think partners are amazing. My husband was at every prenatal visit for both of our kids. Even those early morning ones, you don't feel like getting up. I was like, honey, we got to go. And so, I think partners are incredible. Funny enough, this conference, so two things I want to lift up to you all. If you haven't already seen the film Aftershock, I would encourage you to watch it. It's an incredible, get your tissues ready. It's an incredible film that talks about the aftershock, what happens after the initial shock of these Black women losing their lives to preventable complications. One died from HELLP syndrome, one died from complications of preeclampsia in the postpartum period, but it's told through the lens of their partners. And so it's incredible. We've screened it here at the center. And our 2025 conference, I told you about 2024, which is on technology. Our 2025 conference is on the role of fathers and the role of partners in addressing maternal health inequities, because they're there. They're watching it. They're seeing things play out. Think about the story of Charles Johnson and his wife, Kira Johnson, who died from preventable complications. I'm actually going to be at a conference with him in November. Like, his story is so heart-wrenching because they're there and they see things going wrong, and they're not feeling heard. They're not seeing, themselves being prioritized. And so I think partners, I think family members, I think doulas, anybody that's connected to the birthing person really has a role to play in trying to hold the healthcare system accountable. But these are a couple things that I just wanted to lift up. If you haven't already seen Aftershock, it's incredible. And if you're not already following the work of Charles Johnson, you should, because his story is devastating.
Yeah, absolutely. And we have another question here that's kind of going to, well, leaning towards your previous comment on like doulas. I think when you talk about the was it the Mummies Act, or you mentioned doulas. So can you explain exactly what role like you see like doulas having, mental health care providers? What role do they have exactly in helping to shift the needle to improve maternal health?
I think doulas are incredible, and so it's a both and. Oops, this thing is not working for me. Okay, whatever. I'm just gonna leave it here. Doulas are, how can I say this? Doulas are an incredible opportunity, but we have to treat our doulas right. Doulas are not getting reimbursed at the levels that they need to be for them to even make livable wages for their own families. I know my doula was amazing. I had doulas, both my kids. Doulas were amazing coming to my prenatal visit. They were there throughout the whole labor and delivery. They came to my house afterwards. Like, they're just amazing birthing people birthing professionals that support the person that's going through labor. So I think they have a real opportunity. Some of the ways that we're engaging them here in my center, like I said, we just got a grant where we're going to be working with doulas and helping them navigate this reimbursement process here in Massachusetts. We just got our postpartum care extended to 12 months. It's happening. So that's one thing that's a huge win. It's like, yay, doulas are reimbursed for a longer amount of time. Also, we're looking at ways we can engage doulas to focus on high-risk patients. And so how do we train doulas to be health educators, right? How do we work with doulas in the space of gestational diabetes and preeclampsia? And what are the warning signs for them to work with their patients on? How do we train them and arm them to go into these spaces that they're going to need these skills? And so we are really trying to center doulas here at my research center. We're working with a number of amazing doula organizations, national and local. But I am very encouraged by doulas. I feel like they're a nice kind of resource in the conversation between birthing person and the racist system. Doulas sit in the middle, which is really nice.
Awesome. So for still kind of I guess leaning into that conversation, for like those who maybe do not have a doula, and of course just understanding that like self-advocacy is critically important, especially like during like the birthing process. What would you say, like what's your advice to like those who are like experiencing for people giving birth to like advocate for themselves during the birthing process, which is like obviously like a high stress environment.
Right.
What can you do to get your providers to listen? Because it sounds like a recurring theme that we hear is the providers are not listening.
They don't listen. They don't listen. I think it's you have to have, I hesitate to put the burden on the patient, because the burden is really on the healthcare system. So remember how I define structural racism? It's a system of bad actors. It's not one or two people. So in this space, are there things the patient could be doing? Yes. There's going to be certain advice that you're going to be given in labor and delivery that you may not need, right? Like, do we have to do Pitocin right now? Do we have to get an epidural right now? Like, you can have that conversation back and forth. Now, there is going to, unless it's medically necessary, or the fetus is in distress, or the heart rate is dropping, or all these other like what ifs, what if those what ifs are not present, then that conversation can happen a little bit more fluidly. And I think, just being really clear about your wants, expectations, and holding the system accountable and saying, okay, you and I are getting to a place where we're not agreeing. Who else on the team can I talk to? Is there another nurse? Is there another provider? Like, everybody works in teams. You're not talking only to one provider. And if this is something that happens while you're still pregnant, you have the autonomy and the liberty to switch providers, right? You don't have to see this all the way to the end if you feel like you're not getting the care that you deserve and that you're being billed for. That's really where the rubber meets the road. And so there are things that birthing people themselves can do, but the real onus is on the system. The system should be creating spaces of equitable access, quality delivery, timely initiation of necessary care, making people feel centered and seen. That's on the system. That's not on the birthing person. So,
Yeah.
yeah.
And of course, speaking of the system, we're going to a few of the SNMA students will be going to DC sometime later this week to speak to members of Congress. So what are some things that we could do to support like some of the bills? What kind of like language should we be using? What are like some present things right now that you see at a national level that we can like bring up just for those who are going to give them like language to support those bills?
This is great. So that's going to be a wonderful experience for you guys. There, Cory Booker introduced Senate Bill 1606 that still has not passed. I would also love to get an update on Omnibus 2.0. Where are we with that? It's the suite of bills I talked about. Depending on who you're going to talk to, I would have local stats for their home district. So if you're talking to people from New York, what's happening in New York, what's happening in that space, making sure that you're feeding them local stats, particularly in their catchment area, that always gets their attention. And then seeing whether you're talking to somebody in the House of Representatives or a senator, what bills have they introduced? What is their voting record? So before you go talk to people, how have they voted in the past? I get a lot of requests from elected officials, federal, state, and local, that want to talk to me, that want to talk to my center. Before I get in a room with a new potential partnership, I need to know what your voting record is, right? Because what we're not going to do is let the maternal health crisis be tokenized, right? And people just affixing themselves to a train that's moving. We're already doing Black maternal health work. We're already in a policy and advocacy space. That's an easy win for them, but where's the return from me and my team? So that's kind of the rubric that we use to think about who our partners are, is you got to have some elbow grease in this work. If you haven't already voted in this area, here are the details that we want to leave with you to make you vote differently the next time around. Here's the information that's happening in your home district. What is your commitment, to following this work up? And then you follow up with their team. And everybody has a policy advisor. Policy advisors are beholden to us because we are the constituents. We're the voters. We have the power. And so when you're going into those spaces, go on with your notes ready to be like, okay, in the last session, you voted or you missed this opportunity. Here's where you should have voted, and here's where I think you can go in the next session. And here's what that means for people in your home district. Always tying it back to their location.
Wow, that's very, very helpful. I'm sure it would come in handy for those going. And for one of our last questions here, unless others want to put last minute questions in the chat, what would you what is your advice to students who feel like they've been doing advocacy work like as best as they can and just feel like their efforts make no difference? What advice would you give to those students?
Keep pushing, keep pushing, keep pushing, keep pushing. Collective action, forward movement doesn't come overnight. You plant seeds every day. You get back out there, you do what needs to be done, you hold systems accountable. All of us are working within systems of oppression. Universities, medical centers, medical hospitals, they're all places of oppression. So how do you work within these systems? How do you navigate these systems to get the impact that you're looking for? So collective action, strength in numbers, that works. Organizing works. Having evidence works. Making sure people are abreast of the issues, having your talking points, going in with a universal standardized message. Here are the 3 points that we want to talk about every time we get in front of someone in this space, right? And you keep pushing. You're clear on what the ask is. You're clear on what the return is. You're clear on what the demands are. Advocacy work, social organizing, social justice. It never gets old, and there's always more to be done. And so a couple of medical schools around the country, many medical schools have like curriculums in anti-racism, like even here at Tufts, my colleagues and I published our findings where we trained second and fourth year medical students to be actively anti-racist, right? That was all student-led work. And we looked at how we could empower them, give them the resources. For the white allies, what happens when you see your classmate being mistreated? And for students of color, instead of re-traumatizing them because of their lived experience every day, how do we provide them with cushion and opportunity and resources to navigate these really racist, toxic environments. So the short answer is there's always more to be done. You should never you should not grow weary in your efforts. I think students are amazing resources. They're powerful. You guys represent the next generation and you've earned your place. I mean, I really believe in the power of the students at the collective level. If there are no students to teach, then the school doesn't have revenue. No revenue means that they're going to close. You guys are very, very powerful.
That's true.
Yeah.
And then we have another question here from Facebook. How do you best envision the future of the American healthcare system?
What?
Do you think that vision is possible, and how do you keep yourself optimistic?
All right, I see you guys ate your Wheaties today. How do I envision the future of the American healthcare system? It depends on who's in office. I mean, right now, I have a little bit more optimism than I had a few years ago. I think we have a real opportunity. Unfortunately, the lives that were lost in 2020, just 2020 was such a crazy time, but like the lives that were lost, Breonna Taylor, George Floyd, Ahmaud Arbery, like we don't have the luxury of sitting back and just thinking things are going to change racially in this country. We know that there has to be collective action and a push. So I'm feeling pretty optimistic about the current administration. And the way that I stay optimistic, for me to do this work, the glass has to be half full, right? Like you look at the data, I'm giving the statistics. It's just so Debbie Downer, but I know that I feel a sense of obligation to represent people who are no longer here. I've lost friends to preventable complications. I've lost 2 friends in my personal life that should still be here now raising their children. So I don't have the luxury of sitting on the sideline, right? Like if you have this platform and this privilege, you have to push. And so I'm optimistic because I want a better world for my children. I want my sons to have better opportunities for their partners, right? And just thinking about what kind of world are we leaving for our children's children, right? If we're leaving it in shambles and in a place like United States, 80% of maternal deaths are preventable, that's insane. So there's a lot of work to be done, and you get with people that share that passion, that mission. I have an incredible team, and you just push a little bit every day. That's really what it is.
Yeah. And just you mentioned like the United States, and I'm just wondering, do you know? So of course we know like in developing countries, maternal mortality rates are also bad.
Right.
Do we find that like for women immigrating from like developing countries coming over to the United States, do they equally have bad outcomes in terms of like pregnancy, or like is there any difference?
The longer you stay here, the worse your outcomes are. When you first come from another country, there is a buffering. I want to say that threshold starts to wane. I think it's like 7 years in the United States. But when you first come, there's a nice buffering of protection from your home country, right? And so the longer you stay and you are kind of indoctrinated into this racist healthcare system, this racist country, then that protection starts to wane. And so we see people, who their first child they had when they first came, better outcomes, and the longer they stay, we see a deterioration in that higher levels of allostatic load, higher blood pressure, more physiologic response to stress. That's kind of aggregated by the continued assaults on the body from racism. So yeah, when you first come, you got a window, and then it just gets worse from there.
That is astonishing. But thank you so much, Dr. Ayo. That's it for all the questions we have, and we're almost at time. Thank you so much. This was a very, very, very impactful talk. And again, it's always great to hear you speak.
Like
and
that.
for those who joined, thank you. And of course, this will be recorded, and you can share with your friends and families to watch this as well.
Yep.
Thank you.
You're welcome.
All right. Have a great evening, everyone.
Have a good night, everybody.
Thank you.